We're here at the 17th Conference on Retroviruses and Opportunistic Infections with Joel Gallant, who has been kind enough to do these interviews with us since day one that we've been involved with this programming. And we're so happy that you're here again. And usually Ray Candelaria does it and will not be here this year, but we definitely appreciate the opportunity to have your perspective because you're a treating physician and you're very introspective and you usually cover a lot of resistance, but you say there's not too much happening here. But why don't you give us what your takeaway is from the conference this year?
Well, can't think of any single takeaway. There's some incremental data on antiretroviral therapy, including some data on new drugs that we can talk about. One of the more important studies was ACTG 5202. We had heard the preliminary results of a subset analysis from that study in Mexico City back in 2008, where they had stopped the nucleoside or unblinded the nucleoside arm for those patients who had viral loads above 100,000 because the DSMB had noted a higher rate of virologic failure in people on abacavir 3-TC as opposed to tenofovir FTC. So that was kind of the last thing we heard. So at this meeting we heard the full trial results. And I have to say it was a very confusing presentation because there's so much going on. This is a study that is comparing efavirenz with boosted atazanavir. It's comparing tenofovir FTC with abacavir 3-TC, and so there's kind of 4 different regimens going on, and then you've got the high viral loads and the low viral loads. So I think it was a hard study to encapsulate in a 10-minute presentation. But I think what it predominantly showed us is that boosted atazanavir plus boosted atazanavir is as effective as efavirenz. It's really the first time we've seen a trial showing that a protease inhibitor is as effective as efavirenz. So that was probably the most important bottom line. Then there are a lot of other little nuances that came out of the study, one of which was that tenofovir FTC seemed to have a better lipid profile than abacavir 3-TC. Boosted atazanavir had a better lipid profile than efavirenz, so if you were taking abacavir 3-TC and efavirenz, you had the kind of the worst lipid parameters. It'll take us a little bit of pouring over these data to really make complete sense out of it. But I think the most important takeaway point from that study is that in this case, a boosted PI, atazanavir, was as effective as efavirenz with some subtle differences with the nucleosides.
Do you think most practicing physicians will labor or strain over those small considerations, or will they not take them into account?
Well, I think everybody was puzzled by what happened with that first analysis where abacavir 3-TC or Epsicom was less effective than tenofovir FTC or Truvada at high viral loads, and we kind of were thinking, okay, well, the final study results are going to show us what's really going on. Maybe we'll see the same effect, only less pronounced. We really didn't see it. It was surprising, and it doesn't explain what happened with that high viral loads at that point. In terms of the subtle distinctions, the DHHS guidelines sort of already are consistent with this study without having really seen it. They show efavirenz and boosted atazanavir as preferred agents. They show tenofovir FTC as the preferred nucleoside combination. So I think if you're following guidelines, then there's nothing here that would change your practice. But I think it's an important study.
How strict are you with following the guidelines as opposed to treating the patient? I mean, I suspect. Well, let's let you tell me what it is.
Well, full disclosure, I'm on the guidelines panel, and I am very happy with the current set of guidelines. They reflect what I do in practice, not because I wrote them. I'm just one person on a big panel, but I think they're a good set of guidelines. And so if you look at the current preferred treatment options, it would be pretty rare that I would ever need to stray from one of those. I mean, there are 4 really good regimens in that category. But there are individual situations. Somebody might have drug resistance, or they might have a reason why nucleoside analogs weren't a good choice, where in those cases you might have to go to something else and be a little more creative. But I think it's important that when all else is equal, you should go where the data are. And clearly the guidelines are a very data-driven document that makes a lot of sense.
Okay. And I guess you want to talk about the quad pill.
Yeah, well, it's not just the quad pill, but it's the two studies
Right.
of the Gilead GS9350, which is the new Gilead
Call it
enhancer
PK
or
enhancer,
booster.
yeah,
It's supposed to compete with ritonavir for boosting effect, and that's important both in terms of the potential to boost protease inhibitors, which we now do with ritonavir, and because Gilead has a integrase inhibitor, L-vitegravir, that requires boosting. And so, of course, they want to proceed with their own booster instead of using ritonavir. And in addition, they've developed this so-called quad pill that combines tenofovir, FTC, the 9350 booster, and L-vitegravir all in one pill. And so Cal Cohen presented two studies in one session. One was a comparison of this quad pill with a tripla. And the other one was a comparison of boosted atazanavir with tenofovir FTC, one arm using ritonavir, as we do now, and the other using 9350. In terms of efficacy, the quad pill looked, this is a small phase 2 trial, but it's not definitive, but the quad pill looked as good as a tripla. The 9350 looked as good as ritonavir for boosting atazanavir. So the efficacy looked solid, and definitely they're proceeding with phase 3 trials looking at various uses of the 9350, including the quad pill. The only little glitch, if you will, was that especially if you looked, say, at the tripla versus quad comparison, you saw that the creatinine, a measure of kidney function, was higher in those on the quad pill, and the creatinine, the estimated GFR, which is a measure of renal function that you calculate using an equation, was lower. And this occurred very quickly in people who were on the quad. This was concerning, of course, because Gilead makes tenofovir, which has a potential for nephrotoxicity. The concern was that this could be another drug that was nephrotoxic, difficult to combine with tenofovir if you've got two nephrotoxic drugs. However, Cal Cohen snuck in a third study within that presentation where they actually took 9350 and just gave it to patients as monotherapy and looked at not only their estimated GFR, the calculated number, but the directly measured GFR, which is something we don't do in clinical practice, but you can more directly measure it, and found that while the estimated GFR went down, the actual GFR stayed the same. So what that would suggest is this isn't nephrotoxicity, it's something else. Now they kind of hypothesized that what's maybe happening is that tenofovir, or that, excuse me, 9350 is interfering with the tubular secretion of creatinine, which accounts for a small bit of how we get rid of creatinine, and it's causing that to be elevated without actually damaging the kidneys. So that's a hypothesis. It has to be tested in their phase 3 studies. I think the question that comes up is, okay, we've got this drug that alters creatinine, which is what we rely on to determine whether somebody's developing kidney toxicity, including tenofovir kidney toxicity. How are we going to look for tenofovir kidney toxicity if this number is, if this drug is affecting that number? It kind of
negates your marker.
Yeah, so the hope, I think, the best case scenario would be that all this happens within a couple weeks. You know, you measure their kidney function before you start, you measure it in a few weeks after you start, you kind of establish this new baseline, it's not progressive, and then you just monitor kidney function the way we do now. And if you see a decline in kidney function over time, then you say, okay, that's the tenofovir doing that, or that's something else. That's not the 9350. That's sort of the best case scenario. If that's the case, we could probably learn to live with that, and clinicians could be taught to, you know, reestablish a baseline after starting the drug. But, you know, we do have to make sure that that's really what it is and that it's not a progressive problem.
So this shouldn't interfere with their timeline to launch or anything like that?
No, they're going forward with their phase 3 trials, so I don't think this should interfere with it. You know, it creates an interesting question of, you know, they're not the only group out there that's trying to develop something to replace a tripla as first-line therapy. You've got rilpivirine, which is TMC-278. You got once-a-day raltegravir. Everybody wants to be the next first line.